So I got a call from a patient the other day, and so who was interested in coming to see me. She wanted a second opinion, and this is a patient who had single-station N2 disease, young patient, fit, PDL1 100%.
She saw Dr. Borghaei first.
Right,
Yeah.
right.
Just wanted a real opinion.
So it brings into the fold, do we need to change our calculus on these patients with stage 3 disease who are pushing for surgery, which is still curative, given that we've got durva, or do we still need to think about every patient the same as we did before, that these patients should get, the patients who are eligible for surgery should go on to surgery, even though we have this wonderful data with durva?
I think when we have something exciting like Pacific, you're naturally inclined to extend the benefits of the drug to other patient populations. But we have to remember that stage 3 is a very heterogeneous disease. This trial specifically selected patients with surgically unresectable disease. If you had a patient with surgically resectable disease, I think that's a multidisciplinary decision as to whether that patient gets concurrent chemotherapy with radiation followed by surgery or chemo followed by surgery. And some patients may get post-op RT as part of this regimen. But that's not the setting where durva has been studied, and we should wait for data. There are ongoing studies in stage 1B, 2, and 3A that specifically look at where immune checkpoint inhibition fits in. So through the Alchemist, ECOG Akron is leading this trial with other groups, including Alliance, which Tom leads, and SWOG, and NRG, comparing durvalumab versus observation in surgically resected patients. And those trials are quite far along, so we should have the data in the next couple of years, at least from some of these adjuvant studies. There's also the neoadjuvant approach where you give, in an experimental setting, immune checkpoint inhibition, and we've seen some promising results. So that's also being studied in large randomized trials. So the surgically resectable patient population is a different group, and we should not mix the Pacific data with those patient populations.
Good point.
Absolutely
Good
agree.
point.
I think there are patients, I think that there are patients that are more borderline, which maybe have, multiple nodal stations or PFTs you're not sure about. And I think that in the past, you would do everything possible to get those borderline patients to surgery. And now I think you may not feel as much pressure, and you may choose a chemo radiation route, rather than do everything to get them to surgery.
A few practical considerations, clinical points for as it relates to the Pacific trial. In the past, I was doing concurrent chemoradiation and getting a PET scan 3 months afterwards. Do we need to get a CAT scan right away when we're done just to make assure stable disease so that patients can go on the durva? Is that a message to the clinicians to make sure there's at least stable disease, or do we just go ahead and start the durva without any imaging? I think they had to have some sort of imaging post-concurrent chemoradiation. And if you're going to start the durva within 7 days, that means you have to have some sort of scan showing disease stability. Is that going to change the way it's managed?
I mean, I think for me, they actually found that there was a significant improvement in response with the durvalumab versus placebo. When you
Interestingly, the placebo response rate was 15%. I'm not sure how that happened.
Well, because there's still some sequelae of the chemo and RT that they received. So, I mean, to me, I typically would, get just a non-con chest CT to get a new baseline image of their lungs, frankly, more than anything else. If they develop
pneumonitis or
obvious progression.
Obvious progression.
That's what I've done, is just a scan, and then I sort of monitor them every couple months with a scan just to make sure they're not progressing.
But we have changed our practice a little bit in light of Pacific. Now we are doing, I wasn't doing a CT right after chemo RT, but now I am doing one for all the reasons that were just mentioned, especially the pneumonitis part. I mean, you want to make sure there's not like a grade 1 pneumonitis asymptomatic, but you can see it radiographically, just in case.
And one more practical consideration for those patients who aren't candidates for concurrent but need it sequentially, chemo followed by radiation, can we apply the same data here? Would you be reluctant to use durva in the setting of a sequential approach? Not many of my patients get sequential. We try for concurrent based on survival improvement for concurrent versus sequential, but for a patient in which you do have to give sequential, who's unresectable, chemotherapy followed by radiation, would you consider durva in that setting?
I would.
That's a relatively small subset of patients, and you have to go back to why you did not do concurrent and why you went with sequential in that situation. So that might bear into whether you actually want to do anything, not just durva, in an aggressive manner or not. So I would say the answer is it depends on the patient.
Right, on a case-by-case basis. But there aren't data in that setting, but I'd be very comfortable giving it. But again, if there are performance status issues or other contraindications, of course, no.